We are honored, thankful that Senator Hernandez is here with us today, and let's give him a round of applause. Welcome to the stage. Senator? Thank you.
Well, good morning, everyone, and thank you very much for that kind introduction. It's a pleasure to be here, and I want to thank all of you for taking some time to listen to me, but more importantly, to hear what's going on, not only in California, but within this country with regard to healthcare. So I was asked to talk about looking back on reform and then looking ahead to progress. And I think what I'd like to do is put things into perspective, is to talk about the politics of healthcare. We're seeing it now in this presidential election. But I want to begin by just talking a little bit about the politics in the past, but more importantly, whether we like it or not, how polarizing healthcare is in our political system. If you look at from the time of the Johnson administration, I'll give you an example. When Medicare was passed into law, at the time it was extremely controversial. So much so that at the National House of Delegates for the American Medical Association, they made a resolution that physicians would not take Medicare because it was socialized medicine. Well, it's very unlikely you're going to see a physician today that doesn't take Medicare, and over the decades, it sort of has become part of our healthcare system. And I would venture to say that if you were to pose the question to the consumer and ask the consumer now if government were to take away their Medicare, there would probably be a revolution. But it was controversial at the time. So let's fast forward to the Clinton administration when former First Lady Hillary Clinton tried to do some healthcare reform, and we saw how that went. And politically, it wasn't successful. Continue to move fast forward to the Affordable Care Act. And when you look at the law that was signed by President Barack Obama, it was put into law and then in 2010, but it also was controversial. So much so that it was challenged. It went to the Supreme Court. The Supreme Court found it constitutional, albeit that, yes, that the states had to determine whether or not they were going to take Medicaid. They weren't required as originally was in the law, but nonetheless, it was controversial. Fast forward to this election, it's controversial as well. But I am convinced, and I will go over some of the things that the Affordable Care Act has brought forward, but I am convinced that the consumer is now starting to see the benefits. Yes, we're having some increases in premiums and cost, and yes, some plans are leaving. But I think the history is going to prove that it will work itself out, but more importantly, the consumer is going to see the benefit of the Affordable Care Act, and it's going to continue to move forward. But I will say, though, that the implementation of the Affordable Care Act, in my opinion, is probably the most historical piece of legislation that the country has ever seen in its history with regard to healthcare, and even more so than Medicare. Yes, Medicare is important. The Medicaid was important. But now we are close to ensuring most of the people in this country. And if you look at California, California is taking even a step further. We're ensuring the children of undocumented. We now are going to be asking the federal government for a waiver to allow undocumented adults to be able to at least purchase through the exchange. Perhaps there won't be a federal subsidy, but given the opportunity to purchase health care. So you're starting to see that this healthcare reform is moving forward in a very big way. So what has occurred? Let's first talk about looking back and what has occurred with the Affordable Care Act in the country. And then I want to talk about what California has done, and I think, and I'm going to be proud to say that, I think we've taken a leadership role in. So what has the Affordable Care done since the passage of 2010 with major policy directives such as, for example, the expansion of coverage for millions of Americans, including the expansion of Medicaid with generous federal funding ratios and rate increases for primary care providers. We have a transformation of our healthcare market, including application of the medical loss ratio to ensure most premium dollars go to healthcare, not administration or profits. We have the review of health insurance premium rates to ensure increases and that are justified. We've had an end to pre-existing condition exclusions so that individuals cannot be denied insurance because of their health status. There's no annual lifetime benefit caps. We've created the minimal essential health benefits. We've established insurance exchanges. Now, albeit not every state has chosen to have an exchange. But these are the things that the consumers are starting to see that, yes, guess what? I have a job, but the job doesn't have health insurance or offer health insurance. Oh, I happen to be diabetic or have asthma. Wow. I can actually get health insurance now. I'm not being denied. The consumer is starting to see those benefits. Grant programs and pilots to test new payment models such as accountable care organizations, patient-centered medical homes, whole person care, care transition, innovation models, etc. Almost 7 years later, despite many political hurdles, I say we can declare, I believe, that this has been a success. There's over 17.6 million consumers have gained health insurance. As many as 129 million Americans who have some type of pre-existing health condition, including up to 19 million children, are now protected from coverage denials and reduced benefits. And we have 105 million Americans, including 39.5 million women and nearly 28 million children, have benefited from annual limits on out-of-pocket spending and the elimination of lifetime and annual limits on insurance coverage. So as we see, Americans now have access to critical preventative service at no cost. There's over 14 million more Americans have received coverage through Medicaid since the ACA's first open enrollment period in 2013, and almost 5 million in California. And 2.3 young Americans gained coverage between 2010 and October of 2013 because they can now stay covered on their parents' health insurance plans until they're 26. And because of the medical loss ratio requirements, more than $2.4 billion total refunds will be paid to the consumer. Obviously there have been some glitches along the way. I believe we've still have some work to do. We've had poor outreach in communities of color. We've had inefficient eligibility systems. We've at times have had some inaccurate provider directories. And of course, the consumer occasionally complains about narrow provider networks. And yes, premiums are still unaffordable for many. And I think there's still a lot of work that should and still needs to be done, but we're continuing to work on those issues. So what I'd like to do now is I'd like to talk about California and what I believe California has done to kind of set the standard for the rest of the country. And then I want to talk about my perspective of what I've seen in healthcare and the changes that have occurred since its implementation. And then I want to talk about what we need to do to make sure that it's successful. So what has California done? Well, we're the first to have an exchange. But here's what I've noticed, and you're starting to hear, especially now politically, and you're looking at the rates that have gone up. But what I've noticed and seen is the states that have accepted it, that have embraced the Affordable Care Act, for example, have created their own exchanges, are the states where the premiums haven't gone up as high, we've insured more individuals, and we've been more successful. And because California was one of the first states to form an exchange, I believe we have been way ahead of the rest of the country. We've signed up more individuals. One of the first states to increase the Medicaid expansion. As I mentioned, the number of individuals who are now on Medicaid. There's some states that the majority of their residents aren't even eligible because they didn't expand their Medicaid expansion. We were one of the first states to implement the 10 essential health benefits and to actually define habilitative and rehabilitative services. We've embraced it. Our premiums have gone up, but not nearly as high as other states. If you look at the market, we've had some plans have left, but we still have enough robust plans, and I think the difficulty is trying to find plans in the areas of the greatest need. But I think what has made California successful in its exchange is the type of exchange that we've set up in this state. And the type of exchange that we've done is that we are able to negotiate better premiums because it's an active purchaser, unlike other states. So what I'd like to do is just shift slightly and talk about the changes that have occurred that I've seen in our healthcare system, and then talk about the priorities that we have in California and what we want to continue to do. So I've had the pleasure of being the chair of the Senate Health Committee going on 6 years, just shortly after the implementation of the Affordable Care Act, but right before we actually put it into law. So essentially right after the exchange was signed into law by former Governor Arnold Schwarzenegger. And I've had the opportunity to speak at a lot of various groups, physician groups, provider groups, health plans, hospitals, individuals who do durable goods, prescription, you name it. Because this system has had, it's like an earthquake occurred in our healthcare system with the implementation of the Affordable Care Act. There was a lot of uncertainty. Nobody knew what to expect. So let's fast forward. The exchange, California, everybody's starting to implement it. Yes, there's been some states that have been resistant, et cetera. But here's what I've seen and the reactions I've seen occurred in the healthcare marketplace in general. I've seen a significant amount of consolidation. And it's not just in one segment, it's in multiple segments. You are seeing health plans purchase other health plans. You're starting to see more health plans being very interested in coming into the Medicaid space, Medi-Cal space in California. And in California, if you think about the Medi-Cal space, it's a very difficult space to get into because you either have to be a 2-county model, a COS, so if you're a COS, you can't compete in that, or the geographical. So there's not a lot of opportunity. So you're starting to see health plans trying to get into that space. And if you think about the dollars in California, now albeit we have some of the lowest reimbursement rates in the country, but if you think about the dollars with federal money matching, it's about a $95 billion budget for the state of California. That's huge. So you're starting to see consolidation of health plans. Hospitals, consolidation of hospitals. Medical groups and IPAs, they are growing in leaps and bounds. Now, why is it that we're starting to see consolidations of markets? Well, I think we're starting to see it because of the changing dynamics of our healthcare system, and in order to be competitive, you have to have scale. So we're starting to see the market react. And I watch it, and I think it's good, but I also look at it with a little concern because, yes, it's good to have scale, but we don't want to have scale so much that it causes a monopoly, because if you have monopolization of markets, prices can go up. So I think that's where we have to have a keen eye to make sure that there's still competition, but at the same time, the ultimate goal is to control healthcare costs for the consumer. So let's now talk about what's starting to occur within our healthcare system, and I want to talk about what my priorities have been for the Senate Health Committee and moving forward some challenges that we're going to have to make sure that we're successful. So there's 3 things that I prioritize, now keep in mind, every legislative year over break, we're in legislative break right now, we have our strategic planning meeting, which my staff and I will do it probably within this next month, where we're going to look at what we want to accomplish this next legislative cycle. But we break it down into 3 buckets. And those buckets, the lens that we look at for every piece of policy that comes through the state of California of how we're going to take a position on those bills or how I'm going to introduce legislation. And those 3 buckets are, number 1, is the successful implementation of the Affordable Care Act. And I mentioned that early, first have an exchange, I carried the 10 essential health benefits, I did the Medicaid expansion, the consumer protections, all of that. It's working, it's doing well, California's moving forward. The second bucket is access to care to every single person in the state of California. And when I say access to care, it's to the most vulnerable populations. And if you think about it, the highest cost drivers are in the areas that have the greatest need, but more importantly, have the least amount of providers. Those are going to be the rural or the inner city, and in particular, the communities of color, as I said, who have some of the highest incidences of chronic diseases. So we've done a lot of work on expanding networks with regard to non-physician providers, been carrying legislation, for example, for pharmacists to take a more active role in primary care. The passage of that bill is now becoming a national standard. We've introduced legislation and have not been successful. Look at expanding the scope, not expanding the scope, but allowing nurse practitioners to have independent practice, to use them more in an integrated system, whether it's optometrists. We're looking at trying to make sure that there's access to more patients within rural areas and communities of color. And then the final bucket is controlling healthcare cost. And when I say controlling healthcare cost is to make sure that the consumer has the absolute best value and they feel that they have the best value. And I'm going to give you an example. So I have an opportunity to work with some incredible individuals. I speak on a regular basis, at least once a month. I have breakfast with Secretary Dooley. She's my conduit to the administration to find out how we can work together. I speak with Jennifer Kent. I have dinner with her once a month to make sure that, see how Medi-Cal is doing, how our Medi-Cal program is. And then I also speak with Peter Lee. And Peter Lee's comment to me when we first started the exchange, and even today, yes, we have some concerns about narrow networks. Yes, patients get a little upset about, multiple languages, but what do you think the absolute number one concern that the consumer has? The number one concern they have is the cost of their premium. And even with federal subsidies, the number one concern. So whenever I speak to groups, and here's what I tell them, whether it's hospitals, providers, you name it, I always tell them, I go, look, here's the reality of life that we now live in and the healthcare system that we now live in. We are going to have to see more patients, be better outcomes, be more productive, and guess what? Probably make less money per patient and be more efficient at it. That's the world that we live in. Because the consumer is going to demand it. And if we don't provide that, guess what? The consumer will go to government and government will regulate it. And I still believe in the open market, but I also believe that we have to make sure we have to do whatever we can to control cost. But here's the reason why, and I want to very briefly get into some of the cost drivers and things that we've done, and then we will open it up to some questions. But here's the real reason why we have to do this. This is no longer pre-Affordable Care Act where you're not required to buy health insurance. We now make it a law in this country that we mandate that everybody has health insurance. We don't mandate that you buy a car or an iPhone, you choose to. But if we're requiring the consumer to purchase this, then they are going to expect that they want a low premium, good quality health care and access in all aspects of society. And I think it's incumbent upon government to make sure that occurs. So we've done a series of hearings over the years to look at how we're going to control cost. Big part of it is through transparency. I'm still working on an all payers database. But I think right now, one of the biggest cost drivers that we have that I've spent this last year on is the high cost of prescription drugs. And if you look at our healthcare system right now, every segment of the healthcare market has some skin in the game. With health plans have medical loss ratios. Hospitals, there's always pressures to control healthcare costs from charge masters. Providers, in the provider space, I can't think of one provider that's happy with their provider rates. We have some of the lowest Medi-Cal reimbursement rates in this country, in California that is. But when you look at the cost of the prescription drugs, and I think we need to look at it at the federal level, that is one of the cost drivers, and that's a segment of the healthcare market that is not regulated at all. And I'm not saying that we should regulate, but what I'm saying, where there was no protections within the Affordable Care Act that has some controls of costs of how we're going to be able to do that. So we ran some legislation last year. It wasn't successful to have some transparency in drug costs, a bill that would have required two things: for health plans to report out the cost of the prescription drugs related to the premium dollar, and then advance notification to the purchasers of the prescriptions so that they can get ready to either see if they're going to be able to negotiate a better price and or put it on their formulary. But I really believe that we need to have that conversation to see how we're going to control healthcare costs, but more importantly, drug prices as well. So with that, I believe I was asked to open up to any questions. I'd like to take this opportunity to thank you for allowing me to spend some time with you this morning, but more importantly, your interest in healthcare. So I believe I need to sit over here. Is that correct?
Give a round of applause. Thank you. Well, let me sort of ask this extraordinarily difficult question. Hardball.
Now you know there's two types of questions you can ask.
Okay.
There's good questions and then there's bad questions. The good question is the one that I know the answer to. So you can only ask me good questions.
Well, I'll ask you a hard question, then you can answer a good question.
All right.
You can answer it however you like. But your term is coming up here in a couple of years. I think a lot of people are going to be sad that you're leaving the Senate. Any plans for your career after the Senate?
So
that's pretty easy, right?
Yeah, that's an easy enough question. So I'll tell you, I will be starting my 7th year this next January. It has been the absolute best time serving in the California legislature. Kind of feel like a kid in a candy store. I was placed in the right time in history as chair of the Health Committee, and I think I've accomplished quite a bit. But my next goal is in 2018, I'm running for lieutenant governor. So.
Right, good. I thought I'd give you that opportunity to get that plug in.
Well, thank you.
So let's spend a little time in the weeds of policy for a second. Obviously, you've mentioned transparency. It was a topic at the last legislative session. It'll be a topic on the ballot on November 8th. Some have argued that pharmaceutical costs are the least or among the least regulated piece of the healthcare spectrum. How do you see pharmacy fitting into the broader continuum of care conversation? And maybe also just talk about the difficulty of running legislation, getting buy-in, on this very difficult political question.
So, first of all, let me state that I believe that the pharmaceutical industry is an incredibly important part of our healthcare system. The United States of America has probably one of the few countries that actually innovates and comes up with life-saving medications, which is important. However, I also believe that the amount of money that the pharmaceutical industry makes is so much so that it's starting to affect premiums. I also believe that it's starting to affect the cost of the health care, And I believe that we need to do several things. Yes, they need to innovate. Yes, they need to have the ability to make a profit. But I also believe that they also have to have some responsibility in our healthcare system, like we all do as well. And there needs to be that fine balance. What makes it difficult to do legislation is, as I mentioned, I don't believe in regulating prices, so that's why we have transparency, but it's an industry that is not used to change, and it's an industry that will vehemently oppose any kind, even transparency. That's what makes it difficult. The other thing that makes it difficult for states is there's not really a lot we can do other than transparency types of legislation, because we don't have the ability to alter patenting laws or to deal with issues at a federal level. I believe, though, that whoever the next president is going to look at prescription drug prices because it's starting to affect our national dynamics, and you're starting to see it play out from Sovaldi to the EpiPen to Shravenki or Shravelli, the guy who...
Shkreli
yeah,
or whatever.
So you're starting to see it rise to the level of national prominence or some type of national conversation.
So what do you think that will look like in terms of policy in 2017 and beyond in Sacramento? Excuse me, specifically, will you have an iteration of your previous pharmaceutical transparency bill, or will it be the same? Are you adding coalition members? Are you sharpening your the language or the elbows? How will things be different in 2017?
Yeah, it'll be pretty much the same law. What I didn't like about it is when it came out of the Appropriations Committee, it was pretty much whittled down to, there was a sunset provision, the percentage that we wanted was too high, but it'll pretty much be the same law, probably maybe even make it quite a bit stronger. The coalition will continue to grow, but I think you're starting to see there's a kind of a wave going across the country, because there were several states that are starting to look at who have introduced bills who've run into roadblocks, and those states are going to continue to increase because they're starting to have more of a national conversation now because of prescription drugs. And most of the states, and now it's ironic, even at the federal level, the McCain bill almost mirrors our transparency bill as well. So there's going to be a national conversation.
What's it like being the sort of oversight authority in the legislature, trying to manage the multi-headed regulatory beast of DMHC, CDI, and Commissioner Dave Jones and his different and separate authority, and then covered California with a different kind of activism? How do you... Boy, it seems like if you want to get good policy made, that even if you get good policy passed with bipartisan support, the administration of good policy on the insurance side is extraordinarily complicated because of those different regulatory partners. How is that from where you sit as chair of the Senate Health Committee?
So as being chair of Health Committee, I oversee the policy or the legislation that comes through my prospective committee. And that would be laws that are going to be implemented or would like to be signed by their prospective members, by the governor. But we get some interaction, and there would be positions taken by those various entities, but I don't necessarily oversee or dictate or tell the insurance commissioner what to do or Department of Managed Healthcare what to do. And that's why I meet with Secretary Dooley to make sure we have a working relationship with the administration. That's why I speak with Jennifer Kent to find out that we have a working relationship with Medi-Cal. But our responsibility is to take a position on various pieces of legislation. That's why I put them in those buckets to make sure that they meet at least my policy perspective. Now, granted, the committee itself, votes independently, but with my recommendation, and that's how policies move through the state of California.
Do you think, let me ask a similar question, maybe more directly, and maybe you can just say, I don't want to comment or I don't have a position on it. A lot of people, including Commissioner Jones, would like to see a unified authority in at least the DMHC, CDI silos, and maybe also cover California. Commissioner Jones is a keynote speaker later today. He's had a number of issues with Covered California. What do you think of his idea that there should be one regulating agency, that it would be more administratively effective and bring more, a stronger voice of consumers to the healthcare regulatory process?
So California is probably one of the few states that has it broken down to the Department of Managed Healthcare and California Department of Insurance. And unfortunately for Commissioner Jones, the amount of book of business that's going through CDI is quite a bit less. I think it's probably less than 12, 14%. So the majority of it is on the managed care side. But the decision to have them split is based on what the administration and what the legislature wants. So I don't see that changing in the near future. If you were to put it in one particular entity, would it be better for the consumer? I don't know. I'd say the verdict is still needs to be determined if that's the case or not. Mm-hmm. To say that Covered California is not, doing what it's doing, I would argue that it is. I would say that our exchange is probably better than most states. We have some of the lowest rates. I know there's been a conversation about a public plan or public model of it, but if you think about it, there's very few counties or areas, regions within the state of California that have few health plans. So we're pretty robust, we're pretty competitive, and we control our rates.
Mm-hmm. One of the, I think, central planks of Secretary Clinton's healthcare platform is an expansion of Medicare eligibility from 65 to 55. Some have suggested that that would be difficult to get passed in Congress, particularly if the House remains Republican controlled. And so as a consequence of that, some have suggested that states can opt to expand eligibility through a 1332 waiver. Whether that is accurate or not remains to be seen. But what is your view on whether that would be good policy for the state of California? Admittedly, it's federally driven, or at least federally negotiated. But do you think California would do well to have Medicare expanded from 65 to 55 for eligibility?
So you talk about the public option, or you just talk about Medicare?
Just Medicare first. But if you'd like to talk about the public option,
yeah, I mean, we can have a conversation about the public option. I would think that, I don't know if the state of California, or I've seen any members bring bills forward to sort of have that conversation. Mm-hmm. And I think if we're going to do it, I think it needs to be done first at the federal level and needs to be done nationwide. I just don't know if there's an appetite or if the state has been looking at this right now.
Yeah. It seems like there's a lot of folks who are tired about, when it comes to big policy lifts, right? Because we've just gone through a period of pretty significant reform. Is that the case, that the appetite, I mean, to your point a little bit, that the appetite for big health policy lifts is diminished and we're really talking about smart technical changes that make sense?
Yeah, I don't know. And I would say that California is different. And California is different in the sense because we've done a lot of big policy lifts, especially just recently. I'll give you an example. Mm-hmm. Insuring children under the age of 21 under Medicaid through the Laura bill. Just recently, Senator Laura also introduced a bill that I believe the governor did sign that's going to allow us to lobby the federal government to allow undocumented individuals to purchase through the exchange, albeit without subsidies. Look at what we did. We had a huge policy change during special session, quite a few. Passed the MCO bill. We did the Smoking to 21, which was my bill. Mm-hmm. So California, I believe, unlike the rest of the country, does take on some big policy issues. And so that's why when you ask the question about the Medicare, that hasn't been a conversation, and it's not because the state's not willing to do it. I just haven't sensed, or members haven't talked about it, and it hasn't risen to that level of discussion. But yes, California takes on some big issues and continues to do so.
Mm-hmm. Let me just sort of throw it open. I think we've got a wandering mic or two. Any particular questions that any of you have? Raise your hand and get the comment in that isn't at a hearing and on TV. We've got a mic or two walk around, so if you raise your hand, just we'll get you. Let me ask about I saw Bill Barcelona from CAPG, who I admire and respect and think knows his stuff as well as anybody. In previous conversations, he spent a lot of time working on provider directories. Mm-hmm. And I know that's been legislation that's come and gone and is in the rules and implementation phase now. But it seems like that is a topic at the implementation level that just continues to run into challenges, meaning plans and providers are just going to have a hard time getting that figured out. Any observations on that? Maybe just generally speaking, do you think maybe in this regard, and maybe some others, that policy leaders are just well ahead of the market and that we got to drag the market kicking and screaming to do some of these things?
Yes, there was obviously some concern, perhaps maybe an opposition from CAPG and the providers as well. But again, let me kind of put things in perspective of what we in government need to look at, and we need to react to the consumer because we have to make this work. And yes, California still continuing to take a leadership on this. So what were some of the biggest complaints that the consumers had? They were told and mandated they had to buy this health product. They purchased it through Cover California. They ended up getting a plan. They ended up getting an insurance card. And then they look down the list, make an appointment, find out that the provider or the new doctor or the previous doctor that they had wasn't on there. So, well, we have to address those concerns. So that's why we came up with the provider directory. There have been some glitches, but I believe, and I just speaking to, it wasn't Bill, but their lobbyists, that they're working through it. They understand the need, but more importantly, the consumers' concerns need to be addressed.
Mm-hmm. How about voters' concerns in Prop 61? What do you think? Is that going to pass, fail?
I haven't seen the latest polls. I've seen a lot of the no on it. Obviously, you're talking about the pharmaceutical one, yeah, because there's so many propositions. I kind of lose track of the numbers. But that's a typical example of policy to try to address a concern and look at how much opposition there is. The pharmaceutical industry is, a pretty influential political lobby, not only in our nation, but in the state. Mm-hmm. I'm barely starting to see some yes on it. I think the voters still need to determine whether it's going to pass or not.
Yeah. You got a gut sense of whether that's yes or no going to pass or fail?
I think if it passes, I think it barely passes.
Really? Questions? There you go. Go ahead, ma'am.
Okay. My name is Andrea, and I am Regional Community Advisory Committee. It's a community group that bridges the gap from the community to LA Care. Now, I speak to the community all the time, and I think we all know homelessness is not a migration. It's a multiplication to the state of California. Now, what we're doing obviously is not working. So there's no law that mandates anyone to receive any sort of health care, for that matter, if they are mentally or physically disabled after the age of 18. Who helps those people? Healthcare-wise, we are entitled to get a primary insurance. They are the one exception, the homeless. Okay? So who's there to help them? There are more emergency room visits, urgent care visits. We need preventative health care for the homeless, and we also need better programs to educate civil servants like the police and the shelters for that matter, because obviously it's not working. We need to be able to educate them on how to communicate with those who have mental illnesses, depression, domestic violence victims, victims of molestation and different things like that. They need help.
Thank you.
How do we actually help those people?
Very, very astute comments, and I appreciate and understand all of them. And I will also agree and share with you, if you think about like all the cities that I represent, it seems like more and more you're seeing the problem of homelessness amongst our counties and our cities. So let's first talk about some dilemmas and some problems and possible solutions and what government and what counties and cities and the legislature is thinking about. Well, first of all, by passage of the 10 essential health benefits, one of the 10 essential health benefits is mental health. It is one of the benefits. So here's the dilemma that we have in California, I would think across the country. We have a huge provider shortage of mental health providers. So now you have a service that's provided, but yet you don't have the provider. So number one, we need to work on that, okay? So what is it that we're doing with, well, first of all, what we need to do, we also need to have a conversation about bringing mental health in alignment with physical health. And how do we get those services to those individuals and those patients? But I think it's more than just the healthcare portion of it. We have to look at the social aspect of it. We have to look at housing. We have to look at substance abuse. And yes, we have to look at our law enforcement of how we better train and address that so that we can bring all those elements together. Now, what has California done? Well, obviously, we've had Prop 63, which, you know, we can still have that discussion about how that money has been used. But if you look at what the state has done and the counties have done, I believe there's, I don't think there's an initiative on, but the counties have been trying to put initiatives on to do some housing for homelessness. The state has been trying to do it in various cities as well. So it is coming to the attention of society, and it's something that definitely needs to be addressed, and I agree.
On the question of homelessness specifically, any observations or maybe aspirations, not so much in terms of policy, but what you would like to see maybe the Medi-Cal system be able to do to support people who are in a state of housing insecurity? I know it's hard to legislate that, but DHCS has a lot of tools already in place.
Right. So, well, first of all, like if you look at our most current waiver that we got, there is some money that allows the state to use to combine housing with mental health as well as health care. And I think we need to look at it holistically of how we're going to utilize our resources to work with counties, cities, and bring in more resources to mental health and make sure that physical health, mental health, and preventative health all are working in one.
Mm-hmm. Other questions? Did I see it there? Great. Go ahead, sir.
Hi, I'm Tony Mills. I'm the physician and CEO of the Southern California Men's Medical Group. And I just returned from ID Week in New Orleans, and there was a lot of discussion there about the high cost of antibiotics and the development of antibiotics. And I didn't realize this, but in this international meeting, and they said that the United States is the only country in the world where the government's not able to negotiate drug prices with the manufacturers. And I just, I was curious how that evolved and if there's any way that we can get out of that. Because when you look at the per capita expenditure for prescription drugs in the United States compared to all the other developed countries in the world, we're way ahead of the curve. Right. So.
And that's the conversation that I think we as a country have to have, and the concern that you're having is exactly the concern that everyone is having. So if you look at pharmaceutical drug prices, and a lot of the emphasis right now it's highlighting the new advanced prescription drugs that are coming out, Sovaldi's of the world, okay? Well, believe it or not, the majority of the drug prices that are going up are drugs that have been in the market for decades. Insulin, you look at antibiotics. And here's what happens, and here's the reason why it does this, is let's say it's off patent, very few manufacturers make it, but if one manufacturer makes it, now what? They now have a monopoly and they have the ability to raise that. So we have to have a conversation at a national level in particular to say, look, yes, you need to make some money, but not so much at the expense of the consumer and the taxpayer, because we're now requiring that these individuals have health insurance. And that's a typical example of how we need to change that. But states can't do that. The federal government has to do that.
And just a little more background to your question, Tony. I believe it was 2003 when Part D passed in Congress, which expanded the prescription drug benefit for Medicare beneficiaries. And the chair of the House, I believe it was Ways and Means, it was a representative by the name of Bill Archer, put that clause in that bill that precluded the federal government from negotiating prices. So it's in law as part of that statute. It could be changed at any time. My recollection is about 3 days after that bill passed, he announced his retirement, and he was going to take a job with the pharmaceutical industry, Trade Association Pharma. So there's a little history for you. Any other questions? Yes, ma'am.
Yes. Good morning. My name is Nancy Gomez, and I'm with Health Access California. And you're right, California has made great roadways in implementing and improving the Affordable Care Act. But one area where we are behind is that of rate regulation. I know we have rate review, and that's great. It eliminates, some of the rate hikes and why they happen. But what are the prospects of getting real rate regulation in California? And I'm going to put you on the spot. Can we count on you to carry such a bill before your term is up?
No.
Okay.
Okay, let me explain why. Okay. I really believe that the market needs to play itself out. And that's why when I have conversations with every group, providers, hospitals, pharma, I say it has to work, because if it doesn't work and rates continue to go up, guess what? Then government will step in. I don't know if it's time yet. Here's my concern about rate regulation. If we were to put rate regulation on insurance companies, it's not going to control the rates all around. If you're going to have true rate regulation, then it has to be some type of PUC model where everybody's regulated, including the pharmaceutical industry. That's true rate regulation. I don't know if we're ready for that conversation yet, especially in California, because we're doing a pretty good job at controlling our cost. Now, I'll give you an example. There's regions within the state that it's less than 4% or 2% that has gone up, but there's regions that's gone up as high as 18 or 19%, and that's because of monopolization or consolidations of markets. So as a whole, California, it's working, and the market is working, with exception of a few areas like pharmaceutical drugs. I just don't know if California or if we're ready for that conversation yet, so I can't be willing to carry that bill yet.
Let's give him a round of applause.